very much. Please presenting the next one.
Sir, I'll present, sir. My topic is on central venous access, sir.
Central line. Go
Yes,
ahead.
sir. Yes, sir. Central venous access in patients involves insertion of long, flexible catheters into large veins entering thorax or abdomen. Catheters placed in small peripheral veins have a limited life expectancy because they promote localized inflammation and thrombosis. Large vein offers the advantage of a large diameter and higher flow rates and usage of multi-lumen catheters, which increases the efficiency of vascular access. Main indications for central venous access are difficult peripheral venous access, delivery of vasoconstrictor drugs, delivery of hypertonic solution, delivery of multiple parenteral medications, and also used in hemodynamic monitoring and also useful for hemodialysis and transvenous cardiac pacing. There are many different types of catheters and a number of sites suitable for central venous access with selection depending on numerous factors, including indication and duration of access, anatomy of the patient, local resources, and operator skills and experience. The types of catheters includes singular multilumen catheter, dialysis catheter, peripherally inserted central catheters, impregnated catheters with antibiotics. Major sites includes internal jugular vein, subclavian vein, femoral vein, peripheral or antecubital vein. So central line bundle, infection control is an essential part of vascular cannulation, and the preventive measures recommended for central venous cannulation is the central line bundle, which includes 5 measures, which is hand hygiene. We usually use an alcohol-based hand rub or a soap water hand wash before and after inserting or manipulating the catheters, and then barrier precautions. We use maximal barrier protection, including a head cap, mask, sterile gloves, sterile gown, full body drape for catheter insertion or guide wire exchange, and then skin antisepsis. We usually apply chlorhexidine based solution to the catheter insertion site and allow 2 minutes to dry. And cannulation site when possible to avoid femoral vein cannulation because of the increased risk of infection, and cannulate subclavian vein rather than the internal jugular vein. Uh, and then catheter removal, we have to promptly remove the catheter when it is no longer needed. Techniques of central line cannulation, it could be landmark guided or ultrasound guided techniques. In case of internal jugular vein, the guidance could be either landmark or USG guidance. Under USG guidance, the methods are under aseptic precaution, a short view axis of IJV and carotid artery are viewed, and the IJV is located anterior and lateral to the carotid artery, and it will collapse on the compression. We have to advance needle using short stabbing movements to displace tissue along the path of the needle. We have to determine the distance of vein from the skin, needle visible only as a small high intensity dot. In landmark approaches, we have anterior approach, central approach, and posterior approach, sir, in IJV cannulations. Complications of IJV is misplaced catheter, accidental puncture of the carotid artery, insertion of catheter into the carotid artery, hemothorax or pneumothorax, catheter-related infection, septicemia, venous air embolism. Advantages, it is preferred site with ultrasound for venous access. Hemodialysis can be done, increased success rate, fewer cannulation attempts, and shorter time for cannulation, decreased risk of artery puncture and pneumothorax. Disadvantages, patient discomfort and increased infection rate compared to subclavian vein. And then subclavian vein cannulation also could be done under ultrasound and landmark. But in ultrasound guidance, it is not easily visible because it is blocked by the overlying clavicle. So the method is not very popular. In landmark method, there is infraclavicular approach and a supraclavicular approach for subclavian cannulation, sir. Advantages is patient comfort is seen in the subclavian vein cannulation, and then there will be decreased infection rate compared to the IJV and femoral. Complications are puncture of the subclavian artery, pneumothorax, brachial plexus injury, phrenic nerve injury, septicemia, and subclavian vein stenosis and venous air embolism. And then coming to femoral vein cannulation, this also could be done under USP guidance or landmark guidance. Now, the advantages, it is temporarily favored site for hemodialysis catheters. And then during a cardiopulmonary resuscitation, it doesn't interrupt with the resuscitation efforts in the chest. Complications are femoral artery puncture, septicemia, which is seen more common with femoral vein cannulation, and femoral vein thrombosis. Contraindication is deep vein thrombosis of leg and penetrating abdominal injury, as there is risk of vena cava disruption. Coming to peripherally inserted central catheters, here the catheters can be advanced into superior vena cava from peripheral veins located just above antecubital fossa in the arm. There are two veins that emerge from the antecubital fossa. Basilic vein runs up the medial aspect of the arm. Cephalic vein runs up the lateral aspect of the arm. Basilic vein is preferred because it has larger diameter than the cephalic vein and it runs a straight course up to the arm. PICC line insertion is performed with ultrasound guidance. The advantages are it will eliminate the accidental puncture of the major artery. We can eliminate pneumothorax. For the prolonged usage with minimal risk of infection, PICC line is preferred in critical care, and then less discomfort to the patients. Complication includes catheter-induced thrombosis, especially in axillary and subclavian vein, and then septicemia. That's also.
Fantastic. That is a very comprehensive, excellent presentation. Very, very ideal for theory answering questions. But in word rounds, of course, you will not be asked to give this elaborate and lengthy descriptions. So we'll just go straight away to the PPT, which has got the question answers type, where I have tried to include some ASCII type things also in that, which we will now straight away go without wasting time for that. Okay.
Yes. Yes.
Okay. Is it possible now?
Yes, sir.
So what is a central venous catheter? That is the question that may be first asked. How do
Yes,
you
sir.
define a central venous catheter? You have answered that in your very beginning, that a
Yes, sir.
central venous catheter is an indwelling device inserted into a large central vein, most commonly the internal jugular, subclavian or femoral, and advanced until the terminal lumen resides within the inferior cava or the right atrium. Then only it is, that is, it should go inside the thorax. That is the main aim of central venous catheter. And in this situation, they can ask you what is the CVP, central venous pressure. How do you define central venous pressure?
Sir, central venous pressure, it's a pressure in the right atrial pressure, sir.
Right
It
atrium
represents
means it
the.
becomes right atrial pressure. It is not directly central venous. So this is the very important question, as I thought you'll be answering very easily because we have done a very wonderful job in description of that. So all of you, this is a very common question in the exam. Definition of a central venous pressure is the pressure measured in a large central vein, like either IVC or SVC, inside the thorax, because the respiratory variation should reflect on that. So that is the important. You cannot just keep the catheter in the junction of jugular and subclavian before it enters the thorax. At that level, this is, if you measure that, that is not the correct way to measure the central venous pressure. So the definition of central venous pressure is the pressure measured in a large central vein, either SVC or IVC, within the thorax before the catheter enters the right atrium. So if the catheter is advanced too much and goes into the right atrium, that is not considered as CVP. That is considered only as right atrial pressure. So the location of the catheter should be in the SVC or IVC, but that IVC or SVC should have entered into the thorax, and but before it empties into the right atrium. So right atrium. That is the location and that is the correct pressure of central venous pressure. Now, what are the indications of central line placement? Of course, you have said all the indications
Yes,
are
sir.
in the rough way. It can be TPN also. Did you mention about TPN?
Yes, sir.
TPN,
Total
dialysis,
parenteral.
plasmapheresis, medication administration, hemodynamic monitoring, or giving fluids which are irritant, or when there is lack of adequate peripheral venous access. All these things are the common indications. What is central line care bundle? How is it classified? You mentioned about one bundle only, but there are how many bundles are there?
Uh, this 5 measures only was given in Paul Marino.
Okay, that is the components of that bundle. Now,
Yes,
what
sir.
that will lead to the question: what is a bundle? You have sepsis bundle. You would have heard. This is another bundle which is commonly asked or used. The terminology used. So, what is a bundle?
So it is a group of measures to perform a procedure in a systematic
Very
manner,
good,
sir.
very good. It is a group of procedures, okay, or guidelines or protocols which are evidence-based and have been proved to be useful in preventing a complication. Okay, that is why it's called a bundle. So the central line bundles, there are two bundles: insertion
Okay.
bundle and maintenance bundle. Just like in sepsis, we used to say the initial bundle and then resuscitation bundle, isn't it?
Mm.
Similarly, we
Yes,
have
sir.
a central line care bundle set of evidence-based practices that are implemented together to improve outcome and reduce the risk of central line associated bloodstream infection. This is one of the terminology that all of us should know when we are using a central line. The most dangerous complication is central line associated bloodstream infection. So that is why they say you have to wash, scrub nicely, wear your gown, wear your gloves, wear your mask, wear your cap also, and uh, supposing and in fact they say ICU or a trained nurse should monitor when a person is doing the central line insertion. And if the person is going wrongly in the wrong direction or in a faulty vessel, what should they be the shouting by the monitoring nurse? Because the patient will be conscious. This is usually done under local anesthesia, and you
Yes,
try
sir.
to cannulate the vein, either ultrasound guided or blind anatomical technique, whichever way you are doing. Supposing something goes wrong, a trainee is given the opportunity and he inserts it into the carotid instead of IJV. How will the
Uh,
nurse stop the person doing the procedure without knowing, without the patient knowing that something is wrong being done on them?
he should only verbally communicate, sir,
Verbally,
asking them
what
to
should they
stop
say?
with
That's what I am saying. For example, when you want to give a defibrillation shock, what is the thing you should shout?
clear, sir.
Clear, so that everybody will be away from that. Like that, is there any command or any shouting that has to be done by the monitoring
Stop the procedure, sir.
nurse? If you say stop the procedure, patient will know.
The patient will know. Yes.
So you tell me what is the shouting that has to be done in the next class, or try to Google and find out and tell me before the end of the class.
Okay. Okay,
So
sir.
the insertion bundle consists of these following things: hand hygiene, maximal barrier precaution, chlorhexidine skin preparation and antiseptics, optimal catheter size selection, and daily review of line necessity. You start from the insertion time itself, because the risk of this central line associated bloodstream infection is so high. As far as the central line is concerned, your aim must be always when to remove it as early as possible. So daily review of the line necessity. Do we need it? Can we switch over to a peripheral line? So this should be a periodical review so that we can avoid this complication. Then there is a maintenance bundle, which again consists of every time when you handle the connections. Here it is doing insertion. As much as possible, you should have follow maximum aseptic precautions. Similarly, After incision, the handling should not be taken at a very light level. We should have practiced the same diligent antiseptic precautions while handling these catheters. But nowadays, you find the staff nurses in the ICU are all very casual with changing the IV line or putting the cap, and it will be touching all over. All that casual attitude should never be done. So that is why the maintenance bundle is also given, where hand hygiene, aseptic technique for accessing and changing needleless connectors, like changing the IV set or adding a three-way connector, and standardized tube changing and daily review of catheter necessity. Again, it is another thing, when to remove. That should be always on the mind of the patient, especially if they develop a fever, rigor, chills, and show any evidence of infection. You must think of the central line as the most important culprit. And what is PICC, which you mentioned? It is the peripherally
Peripheral
inserted central catheters inserted through basilic or brachial veins. For purpose for this is mid-term and long-term central venous access. Okay. Why IJV is the most preferred site for the central venous access? This question also she has already answered. And the intrajugular chosen for reliable anatomy, easy access, low complication rates, especially if you make an extravasation by compression, you can easily stop the bleeding, which is not possible with subclavian, and which is also will be more with femoral. So the lowest incident of extravasation and hematoma formation is with IJV, because we can apply good compression and stop the bleeding, and the ability to apply ultrasound guidance during the procedure. So these are the reasons that you have to answer if the examiner asks why IJV is the preferred access. And describe, automatically they will ask you about the anatomy of IJV. If they ask you about IJV catheter, then definitely you can expect the question on anatomy and what are the approaches, merits and demerits. Of course, he has already answered all that. The IJV is located anterolateral to common carotid artery in the superior portion of the triangle. It is created by the two heads of the sternocleidomastoid muscle and the clavicle. And it can be accessed by anterior approach, central approach, or posterior approach. About the bifurcation of the sternocleidomastoid muscle. Central approach is the most commonly used, and posterior approach is considered safest, and the anterior approach to be shortest and easiest. Okay, so these are the anatomical landmarks where you can see this is the anterior approach, this is the central, this is the posterior. This is the external jugular vein, which has been drawn as big as this. But this is the sternocleidomastoid with its two divisions. This is the clavicle. The lower line is the clavicle. And advantages and disadvantages of subclavian vein cannulation, which also, did you mention those things?
Yes, sir. Advantage, patient comfort,
This has
advantages,
low rates of both infection and
infections,
thrombotic
and yes, sir.
complication. And definitely patient comfort is more because he is free to move his neck without any problem.
Yes, sir.
And it is accessible in trauma when the cervical collar, this is an important point. If polytrauma case comes with suspected cervical spine injury, first thing we do is apply a cervical collar. And in that patient, if he is very hypotensive and we have to give massive transfusion or rapid infusion, subclavian is the ideal choice for instead of IJV, because the cervical collar will prevent the approach to IJV. And disadvantages include high risk of pneumothorax, less accessibility to ultrasound because it is behind the bone, and it is non-compressible location. Okay, these are the three important disadvantages. You should subclavian must always, first and foremost, is pneumothorax. Second is it is not ultrasound grade friendly. Third, if there is a counterpuncture, compression is very, very difficult. And anatomical relations of subclavian, anterior and superior to the subclavian artery. Lung is infromedial. Phrenic nerve courses just deep to the brachiocephalic vein at the confluence of subclavian and internal jugular. And brachial plexus and right-sided thoracic duct are close. So these are the important structures which are very close. So this question also they may ask you what are the structures which can be injured during attempted subclavian vein cannulation. You can injure the subclavian artery, you can produce a pneumothorax, you can produce phrenic nerve injury, you can produce brachial plexus injury also, and thoracic duct injury also can happen. And access to subclavian advantages and disadvantages are can be accessed above or below the clavicle, which she mentioned, supraclavicular and infraclavicular. And though infraclavicular method is more commonly employed, supraclavicular is a very short distance, well-defined landmark for insertion at the clavicle sternum triangle and angle, and the shorter distance to puncture the vein. And there is a straight path to superior vena cava with less proximity to the lung. So pneumothorax incidence is supposed to be less with the supraclavicular approach rather than the infraclavicular approach. And when is the femoral vein preferred? Advantages and disadvantages. Of course, it's a site for patients who are critically ill, especially patients who have burns on the upper part of the body and with the sparing of the lower part. You will find difficulty in accessing the veins either peripherally or IJV will be very difficult. Even supraclavicular will be difficult. In those patients, femoral will be the ideal site for resuscitation purpose as well as for monitoring also. And easily compressible and helpful in trauma and other coagulopathic patients. Pneumothorax is not at all a problem because we are well away from that. The free movement of the arms and legs compared to the other things, and increased, but the problems are it can have thrombotic complications, especially femoral vein thrombosis is a notorious one, and it's likely the increased catheter associated infections because the groin is already a contaminated area. And femoral central line will not measure the central venous pressure accurately as you do with the subclavian or IJV. Compared to that, the measurement will be slightly fallacious. And what are the boundaries of femoral triangle? Where the femoral vein is located?
Sir,
This is an anatomy question. You can expect.
Medial border of medial.
yes, sir.
Medial
Medial
border.
border of sartorius, sir, and medial border of adductor longus, and we have inguinal ligament superiorly, sir.
Three muscles are there. Adductor longus medially, sartorius laterally, and inguinal ligament superiorly. What are the types and size of central venous catheters? How many lumens are there? This is about the catheter types.
Yes, sir. Multi-lumen catheters. Triple lumen is there, sir. Single or multi-lumen catheters.
So how do you classify the types of central venous catheters?
Single lumen, multi-lumen, sir, and dialysis catheters and peripherally inserted catheters. Sizes we have ranging from 4 to 9 French catheters, sir. 7 French we usually use, sir.
So the types are actually non-tunneled and tunneled hemodialysis central venous catheter, single lumen central venous catheter mainly for infusion. And the sizes are non-tunneled hemodialysis central venous catheters are the biggest. This comparatively bigger than the other one, 7.5 to 13.5. Whereas tunneled hemodialysis catheters are 14.5 to 16 French size. Single lumen for infusion is 5 to 8 French. And the size in outer diameter is 3.85 and 4.5, like that. It goes on aging. What is the relationship between the French gauge and the standard wire gauge? This is the common question they may ask you if the measurements are given in French gauge and millimeter.
French indicates outer diameter, sir.
And question is, what is the relationship between the two? Now, from this itself, you can easily find out the answer. The values given here in French and millimeter, if you compare them, you can get the answer for that.
French is 3 times the millimeters.
3 French gauge divided by 3 will be the outer diameter in millimeter. Okay.
Yes.
Roughly take, instead of 11.5, imagine this is 12 and you are going to divide it by 3. What is the answer?
4, sir.
4. It is roughly 3.8. Okay. Similarly, if you divide 16 by 3, 5.3. Okay. So French gauge number divided by 3 will be the outer diameter in the standard wire gauge in millimeters. Okay, that is the relationship always. Whether it is what are all the cannulas or catheters which are measured in French gauge apart from the central venous catheters?
Foley's catheter,
Foley's
Ryan's
catheter, suction catheter.
NG tube, isn't it?
Yes, sir.
So they are also measured in French gauge. So this is a very common question in the examination. Relationship between French gauge and standard wire gauge. French gauge number divided by 3 will be the standard wire gauge outer diameter in millimeter. Okay, that is the relationship. Now, something like an ASCII, what is shown here and how and what is it used for? Are all of you able to see the picture there?
Yes, sir. For peripheral nerve catheter insertions.
Very wild and wrong guess.
Sir, is it used in endovascular OT procedure for catheter insertion, guide wire insertion?
Here it is, all the parts are given. It's a sheath, there's a dilator, there's a guide wire, there is a French size indication, there is a
It is
side
a
arm which
vascular
is a stop.
sheath which can be inserted in the central line. Central
This is called the
vascular sheath.
introducer sheath. This is called the introducer sheath. Okay. And they are large catheters which are of 8 to 9 French. If it is 9 French, what is the standard wire gauge relationship? How many millimeters outer diameter?
3
sir.
millimeters.
3 millimeter. Okay, that are placed to facilitate the passage of temporary vascular devices such as PA catheter or transvenous pacemaker. Okay, so this is the introducer sheath. And the introducer sheath is first placed and the device is then threaded through the sheath and into the vessel. Sometimes without the PA catheter, you can use this sheath itself for what purpose? You have a side arm tube and a 3-way, all these things. What is the purpose? Why they should attach it to the introducer? Because this sheath itself can be used as for infusion. Okay, these catheters also serve as standalone devices for rapid infusion, given their large diameter and short length. Okay, so it is not necessary that you should always introduce a PA catheter or a pacing wire. You can use this itself. After removing the PA catheter, this sheath can be left behind as a transfusion device, as a standalone transfusion device. And when paired with pressurized infusion system, flow rates up to 850 ml per minute have been achieved. Okay, you can give up to 850 ml per minute. So if any examiner asks you which is the best method of giving maximum fluid replacement, you can say introducer catheter with a pressurized infusion system. You can deliver up to 850 ml per minute, which means multiply it by 60 for 1 hour. Runs to some 5 liters, more than 5 liters. Okay. What is shown here and describe its characteristics?
So this is
Very common
central
which
line
all of you are very familiar with.
Yes, sir. Central venous catheter.
Central venous catheter. What type of central venous catheter?
Multi-lumen, triple lumen catheters. Triple lumen catheter.
You must always say the full description. It's a color-coded triple lumen central venous catheter. Okay, that is the answer that you are expected to write in the ASCII answer. Color-coded. What is the color coding? What are all the colors that are present there?
Sir, we have white, brown, and blue, sir.
Blue.
Medial port, distal and lateral port, sir. And we have 116 gauge and 218 gauge in this catheter.
Okay, that's the size. What are the purpose of each lumen and how do you use it?
We use it for IV fluids and vasopressor infusions.
What is the white for? What is the brown for? What is the blue for?
Brown for CVP measurement, central venous pressure measurement, sir. White is for vasoconstrictors, blue is for vasodilators.
Okay. You lose 6 marks on that. If it is 2 marks for each line, you are going to lose 3 marks. 6 marks. Okay, it's a triple lumen central venous catheter which has different sizes, often color coded: distal white, middle blue, and proximal brown. Okay, the distal white lumen is the smallest, used for sampling, drawing samples. What did you say for that, Vidya?
Sir, vasopressors.
No, it is for samples. Okay.
Yes,
Middle
sir.
blue is slightly larger for medications, whether it is vasopressor or other vasoconstrictor, whatever drug you want to give, you give it through the blue. And the proximal brown for large fluids and blood products. Okay. So blue is for the transfusion of blood products or fluids. I mean brown. Blue is for medications. White is simply for drawing blood sample whenever you want to take a blood sample for any analysis. Okay. Right. So these are the things that you have to keep in mind with regard to CP monitoring. Can we go to the next topic?
Yes, sir.